just want to check one more time. Your audio is intermittent and mine is continuous. Having said that, things we're good. Is my audio good and
Yes,
clear?
you're coming in loud and clear, Dr. Davis.
Thanks. Okay, so I'll jump right into this. The the sort of the intro to this is to tell you a little bit about trauma. In the mid 90s, the CDC discovered an exposure that increases the risk for 7 out of the 10 leading causes of death in the United States. And that same exposure at moderate or high doses will shorten lifespan by 20 years. It's from the CDC. The estimate of how common that exposure is between 20 and 40 million Americans have a significant dose. You would think then, if you had an exposure that increases risk for life-threatening illness and decreases lifespan, that we would screen for it, but the short answer is we don't. There are screening tools available, some on the SAMHSA website, but in general, as we survey primary care and other medical practices, we don't screen for it, and even to some degree in behavioral health, we aren't screening. So the risk factor I'm talking about is psychological trauma. And when I'm talking about psychological trauma, I'm hearing somebody else, by the way. Somebody's got their mic open and typing.
Your entry is not valid, or the meeting has not started yet.
I might want to wait until
your access code or meeting number followed by pound.
We mute whoever has just logged on. I think Michelle Hallman.
Enter your attendee ID number, followed by pound. If you do not know your attendee number.
There we go. Thanks. So the risk factor that we're talking about is psychological trauma. Now, by that, I mean any event or series of events that is perceived by the person to be harmful or life-threatening, which occurs in the context of helplessness, some degree of helplessness. You'd imagine the most helpless people under those circumstances would be children. And in fact, the CDC statistic I was giving you at the very beginning do relate to childhood trauma, to developmental trauma, psychological trauma that occurs in the first 18 years of life. Now, the reason that this is relevant is that I believe, and many of my colleagues believe, and some of the literature is beginning to support, that the reason we struggle with chronic pain treatment so much and turn to things like high-dose opioids in the past is that we don't screen for psychological trauma, and yet it's there and it's driving a lot of our chronic pain problems. A lot of the people that are labeled chronic pain patients, as you'll see in this presentation, actually do suffer from significant doses of undiagnosed and untreated psychological trauma. It's also relevant because I believe, and many of my colleagues believe, that our failure to solve the opioid crisis is also related to undiagnosed, unscreened for, and untreated psychological trauma. And we'll look at some of the slides that sort of cue you in as you read these slides from the NIH and so on. You won't see much mention of psychological trauma, and see what I mean. So the goal of this presentation then is to define pain in a way that includes the role of psychological trauma, to give you four reasons or diagnoses that might lead to chronic pain, and discuss the implications that broadening our horizons to include psychological factors, especially trauma, in the diagnosis and treatment of pain will make a difference in the opioid crisis, and yet there will need to be changes in the healthcare delivery system to implement. So let's talk about the opioid crisis, because it's pretty much unavoidable to talk about pain without talking about the opioid crisis. I did a little bit of research to try to find out when we really got after limiting access to opioid in this country by censoring and working with prescribers. I found out that it was about 2009, 2010. This is from the Government Accounting Office, and it's a report to Congress that talks about the number of regulatory investigations tripling between fiscal years 2009 and 2010. So the DEA is really getting after prescribers like me in around 2009, 2010. And lo and behold, when you superimpose the 2010 line on graphs of what's been going on in the past 15 years, you see a very small dip right at 2010. That's no accident in the number of opioids, or the amount of opioid prescribed. This axis really is morphine equivalents per day. So we see per person, per chronic pain patient. We see this small dip, maybe because some of the overprescribers were eliminated. So that sort of confirms that 2010 is the inflection point. But now if you superimpose a line through 2010 on overdose deaths involving opioids, you see something kind of striking. First of all, that 2010 line, you see the heroin, which is this light blue line, you see the heroin overdose deaths start to shoot up right at 2010. Probably not a coincidence. And then fentanyl later. And because of these two, you see an increase, almost exponential looking, in overdose deaths due to prescription and non-prescription opioid. Overdose deaths due to prescription opioid really didn't change all that much. It sort of slowed down. This rate of increase has slowed down maybe a little bit. So that's a good thing. So there's obviously been a shift from around 2010 from prescription overdose to street drug overdose. And one of the questions I'm going to pose to you all is, who are those people, and why are they shifting from their prescription opioid, which was limited starting in 2009, 2010? Why were they shifting to the street? And the long and the short of it is, I'm going to tell you, I don't think it's all about addiction. Remember, I was talking about trauma and how we think it relates to chronic pain, that a lot of chronic pain and opioid use has been driven by underlying psychological trauma. Well, here is an example of how we aren't cued into this yet and why this talk is relevant and important. Just earlier last year, the NIH launched the Helping to End Addiction Long-Term Initiative. This is a big trans-agency effort, and this is from that effort's website. It talks about this initiative will build on extensive, well-established NIH research, including basic science, on the complex neurological pathways involved in pain and addiction, and goes on to talk about opioid use disorder. And Matt, you can see the focus is still on addiction and not on trauma or underlying psychological factors. So that's the preamble. Let's stop for a moment and take a look at what chronic pain is. Remember, I promised you 4 categories or types of pain, of chronic pain, that I'll present to you, and then see what happens if we view our patients and our opioid crisis and our public health system through the lens of a lens that includes all 4 possible diagnoses. We'll get to a different place. So a little bit dry for the next 10 minutes. I apologize for that. A little bit of the neuroscience. What you're hearing is part of this talk that stands on the shoulders of primary care and neuroscience researchers before me. But for a long time, we've understood what nociceptive pain is. In the 80s, 90s, 2000s, we started to understand what neuropathic pain from physical nerve injury is, so diabetic neuropathy, that sort of thing. And more recently, we're starting to understand that experiences, particularly traumatic experiences, can cause a type of neuropathic pain, a central sensitization, if you will. So I just wanted to put that as a timeline. We'll start with nociceptive pain. I picked 10,000 AD just for the heck of it, because we've understood this forever. About 20 years ago, nociceptive pain, or pain in general actually, just pain, was defined as an unpleasant sensory and emotional experience associated with real or potential tissue damage, or described in terms of such damage. So here they're linking pain to potential or real tissue damage. There has to be tissue damage or stress on tissues, inflammation, too much cold, too much pressure, too much heat, something like that, or inflammation to trigger pain. That's 20 years ago. And Descartes drew this about 4 centuries ago. He drew a diagram showing what nociceptive pain is all about. That there's some sensor, in this case a sensor that senses too much heat in the foot, fires a signal up the nerve into the brain, and this person perceives fire and will move their foot out of the way. And this underscores the nature of nociceptive pain. It's required for survival. If this person couldn't feel the fire, someone who is born without the ability to sense nociceptive pain, to sense too much heat, too much cold, too much pressure, or inflammation, which is actually low pH, generally they won't survive past teenage years. Too many injuries will be accumulated and infections. Nociceptive pain can be diagrammed as the transduction of too much pressure, cold, heat, or inflammation, something that's noxious that can hurt us, by specialized little nerve endings called nociceptors in the tissues, which fire a peripheral nerve. A signal is transmitted to the spinal cord, the central nervous system, where it's modulated, then we perceive it eventually in the somatosensory cortex that there's something going on in this person's case in the bottom of the foot. They've burned their foot. Here's a diagram of the same. Nociceptive pain, there's a pain stimulus. Again, there has to be a pain stimulus, and that is processed just lumping all that last slide together, it's processed through the central nervous system, and out comes pain and disability. There's also an emotional component to it, which is generally not too strong when we're dealing with acute pain. But with chronic pain, we see more of the emotional component. So examples of this, nociceptive pain, are these common things: back pain, fractures, arthritis, radiation fibrosis from cancer, and people usually will describe it as sharp or dull or aching. That's pretty typical. Now, neuropathic pain is a little bit different. Neuropathic pain from tissue injury. In this case, there's no transduction of a painful stimulus. There is no noxious stimulus. The pain comes from within the nervous system itself, either peripheral nerve, such as perhaps the case in diabetic neuropathy, or in the spinal cord, such as the case of central sensitization syndromes or spinal cord injury, or even the brain from thalamic injury. An example would be phantom limb pain. There's no tissue, so if we think about phantom limb pain, then there's pain in the foot being perceived, but there's no trauma, no too much heat, too much cold, too much pressure, or inflammation in that foot. There is no foot. So that old diagram doesn't work. We have to take the pain stimulus away and say instead, there's a physical injury to the nervous system that modifies the nervous system somehow so that it doesn't process sensory stimuli correctly. It might even make them up, such as the case of phantom limb pain. Phantom limb pain is a lie. The brain is being told the foot hurts and there's no foot. There's really no pressure squeezing on the ankle, something like that. Altered sensory processing is the key. So even a non-painful stimulus can be perceived as painful, or there might be no stimulus at all and simply pain signals sent up to the brain from the central nervous system or peripheral nerve. What I'm diagramming here is a case where a patient might be exquisitely sensitive to light touch. Think post-herpetic neuralgia. Think some people with diabetic neuropathy that can't put socks on or have to stick their feet out underneath the bed because they can't stand the sheets rubbing on them. Same thing, person with shingles can't wear a shirt a year later after the lesions have healed. Something has changed about the sensory system, and we call that altered sensory processing. So that purple is the key. What made it change? Well, that's beyond the scope of a talk like this, but physical damage to nerves changes the way our sensory system, particularly the central nervous system at the spinal cord and other levels, processes incoming information. These are examples of neuropathic pain due to tissue injury. So this is the second type of pain I'm talking about. Spoke about neuropathic pain a moment ago. I mentioned diabetic neuropathy and post-herpetic neuralgia, phantom limb pain, complex regional pain syndrome. I believe opioid-induced hyperalgesia probably works this way. I believe in the case of opioid-induced hyperalgesia, there's a change in the nervous system consequent to the medication, such that there is altered sensory processing. Now, what's interesting about this is that people will often describe it as burning, shooting, electrical, with heightened sensitivity to stimuli. Different terms will be used. So having set that, that's sort of setting the table for talking to you about what I want to talk about. So we've known about those two types of pain. We talk about them a lot. They both derive from tissue damage, nociceptive pain and damage to peripheral nerves or central nervous system. There has to be damage to the tissue for those first two types of pain I've just described to occur. So let's talk about neuropathic pain from experiences, things that can damage the nervous system without ever really touching the person or causing physical tissue injury. This is hard to get our heads around. But in 2011, and then again in 2014, the International Association for the Study of Pain updated that old definition of pain that I told you about earlier. They said many people report pain in the absence of tissue damage. So now they're disconnecting, they're unlinking pain from requirement of there being a requirement for tissue damage, and they're saying this usually happens for psychological reasons. Now that's a terrible statement. It makes it sound like it's in somebody's head, and I hate that, but that's what they said for lack of better terminology. I would just say this usually happens because of central sensitization, changes in the nervous system that aren't related to tissue damage. But they're acknowledging that tissue damage is not a prerequisite for having chronic pain. Now here's an example in a slide where there's no physical injury but trauma, say child abuse, say a war or disaster. Guess what? That also alters sensory processing of pain stimuli, which is kind of why I set you up with those other slides. In response to something traumatic, so psychological trauma, remember, that's an experience that we perceive that could damage us or could be life-threatening even in the context of being helpless to do something about it. Those are kind of the prerequisites for something to be really a traumatic experience and change the way our nervous system works. Unfortunately, our nervous system does this. Probably, this is teleologic, but probably so that we will never go anywhere near that situation again. So there's a change in sensory processing such that, same slide, non-painful stimuli can be perceived as painful, but no damage to tissues or nerves. Simply a traumatic experience that has injured the nervous system. So that's a concept that's key to what I'm laying out here, and I think key to understanding the opioid crisis and more. These folks will often describe pain as cruel, punishing, fearful, and horrible. This is the third type of pain, pain from experiences that are traumatic. Maybe we should call it trauma-induced hyperalgesia. Last little diagram, trauma changes the way the nervous system works. It strikes us at the root of our healthcare, of our health system. And there are many consequences to those changes in the nervous system. I mentioned shorter lifespan, chronic pain, chemical coping, insomnia, anxiety, depression, addiction, fatigue, and more. Those are the fruit of the trauma tree, as we say here where I work. The biological changes underpinning that include nervous system reorganization, a change in the neurohumoral system, a change in the inflammatory state, increase in meta-inflammation, altered immune system function. And all of that gets down to changes in the way the DNA is read and transcribed, and we actually know that. Trauma, psychological trauma where a person is physically unharmed and there's no tissue damage can do all of this. So that's a really important slide because when people come to the doctor with chronic pain, all this other stuff may be going on, but for a variety of reasons, pain is the chosen chief complaint. Maybe because it's more socially acceptable than saying I'm anxious or depressed or I have an addiction disorder. And maybe more likely to get a reaction from an allopathic provider. So having said that, I think I owe you folks some evidence at least that psychological trauma leads to altered sensory processing. So I've got three types of research here, 3 research papers from relatively recent times, using 3 different experimental painful stimuli on populations who study populations where the control had no history of psychological trauma and the study group had a history of psychological trauma. Pick the one in the middle. There were higher ratings to hand immersion in cold water in psychological trauma-exposed women compared to non-trauma-exposed controls. There are 2 other methods that I don't need to go into. The slide will be available to you if you want to look them up. 2 other methods of assessing the same thing, and no matter how you go about assessing the nervous system sensory function, there is a change in central processing evident in people who've been exposed to psychological trauma, a lowered pain threshold. So we've got some human evidence of that and a fair amount of animal as well. There are animal models of PTSD that involve cats and changing cage mates all the time. So how do people with pain from traumatic experiences present to a person like me or you folks that are clinicians out there? Well, they'll often present with diffuse polymorphous pain, think fibromyalgia. They'll present with chronic increased back pain, chronic headaches, chronic abdominal pain. Now, I did a little experiment. I went to one of our local community health clinics, and we looked at the patients that had been referred to us after we got to about 100 to my clinic that our psychologists felt had a significant dose of psychological trauma, both either childhood or adult. And the diagnoses we found in their charts, we found psychological trauma, PTSD, in none of the charts, incidentally. These people were all sort of compartmentalized in the medical system with chronic pain complaints, fatigue, and other things. Here the medical, we found chronic back pain, headaches, chronic abdominal pain, and those are not really diagnoses, but then fibromyalgia, dysautonomia, joint hypermobility syndrome, chronic Lyme disease, all these things. Now, some of those are real severe medical problems, but what we found is when we did some investigating, none of those diagnoses were actually true below the fibromyalgia. They didn't have dysautonomia, they didn't have chronic Lyme disease, they didn't have dystonia, they didn't have rheumatoid arthritis or lupus, but that's what was kind of in the chart to try to explain on a medical basis. These are medical people trying to explain pain due to traumatic experiences in their patient. Now, I said to you that psychological trauma, PTSD, increases lifetime risk for the top 7 diseases that kill Americans, and that's pretty common. It's also more common in wealthy countries. I thought that's interesting, and actually the U.S. ranks in the top 4 in studies looking at the prevalence of PTSD. More to the point, in the U.S. we don't really screen for or treat psychological trauma effectively. Now, I found some research to this effect, and I'm going to reference it in the next slide or two. But PTSD and psychological trauma are dramatically undiagnosed in our country, not just because we don't screen at the front end in primary care and medical specialists, maybe surgeons who are considering doing a chronic pain procedure, but also on the behavioral side. Miley et al. In 2016 found that about 85% of cases of PTSD were undiagnosed, even in academic or well-respected mental health, behavioral health clinics. They were just missed. They went in and did gold standard PTSD workup and found that PTSD was not in the chart. Another problem we have is that short doctor visits really limits the amount of screening that our primary care providers can do. That's a problem we have. We really have undervalued behavioral health. We all know that. But we haven't really understood the importance of psychological trauma, medical illness connection. That really hasn't sunk in yet. Obesity, heart disease, smoking-related illness, addiction disorders, chronic pain, and down the road, the opioid crisis. And my thesis is that most of that is driven by psychological factors. This is that study, if you wanted to look it up, Miley and O'Brien. This was looking at mental health and outpatient teaching hospitals. The diagnosis of PTSD the diagnosis rate was as low as 4%, whereas the prevalence in the population in those clinics was known to be between 14 and 50%. So they're really missing PTSD. So even when someone like me, an MD, refers for behavioral health evaluation, the whole psychological trauma piece isn't going to come back. So we really have a large population of traumatized individuals that we don't know about, and we have sequestered in the medical system, therefore. And maybe treating for anxiety and depression, but not the trauma. I'm going to skip over that for time, the ACE study. I'll just relate to you that if you don't see these people, if you're not in a clinic, that people who have pain related to psychological trauma, trauma-induced hyperalgesia, if you want to call it that, they'll say things like, nothing works for my pain besides medications that seem to have psychotropic action, like opioids, which do have psychotropic action, benzodiazepines, etc. They'll have diffuse pain often with no clinical cause evident. This is what they look like. A lot of somatic complaints, can't sleep, fatigue, a lot of other things aren't working well. Their disability seems to be out of proportion to clinical pathology. They keep coming back asking for help. They often have emotionally charged behaviors in the office, like crying. And if they say they cry in pain, we also went back and anecdotally, retrospectively looked at this. Anyone who said I cry in pain had a pretty high developmental childhood trauma score. That was pretty remarkable because crying isn't a typical response unless there's been trauma to the nervous system. So that's the third type of pain, the one I really wanted to relate to you folks. The fourth is emotional pain. Social rejection, grief, depression is painful and will recruit the pain circuits in the brain. If we do functional MRIs of people who are going through acute grief reaction or social rejection, we'll see that the pain circuits are firing as well as mood dysregulation and anxiety. And we find that also many of our patients can't distinguish between depression, anxiety, and pain. They feel depression and anxiety as pain. They'll tell you, I have chronic pain, I hurt. In my current residential treatment program, after about 2 or 3 weeks, we'll often see people go, yeah, that was something painful, but this other is anxiety and depression. I'm starting to see the difference. It's something we usually learn in early childhood, or to the teenage years, but often people don't have this down. So they'll talk about pain when they're experiencing depression or anxiety. And of course, what medication might they have gotten 10, 15 years ago? They would have gotten opioids. So let's stop with the dry stuff and move on to the last 10 minutes or so. Can real pain occur only for psychological reasons? Good question. And here is a patient from about 10 years ago who came in with her husband to see me, drew this pain diagram. And you notice she says over here on the side, my legs hurt so bad it scares me. She had a lot of emotional content in her pain description. She can't organize herself. She's totally, brain fog. She was diagnosed with fibromyalgia, but incidentally, she'd had the diagnosis of rheumatoid arthritis and a number of other diseases as well that didn't really fit because she was seeing medical people who were trying to explain this. When I met with her and her husband, they couldn't really tell me when this began relatively suddenly. They couldn't relate anything that happened to her. She wasn't in the ICU. She had no toxic exposures, no chemotherapy. I couldn't find a reason for this. And her exam was fairly normal, except she was tender all over. She had that hypersensitivity all over, that hyperalgesia. Well, this was the actual, eventually this came out. She was actually caught up in a hostage situation. She was unharmed, but the sheriff's deputy had to shoot a guy who had a knife to her throat from behind her, out behind her. So she remembers hearing the bullet go by her ear. And the story of the theme of we don't recognize psychological trauma really runs through this case. I saw her 3 years into this. They'd lost their house. She'd lost her job. And no one had really picked up on the fact that that pain situation began about 1 month after this event. And in my first meeting with them, I kept asking, when did this start? Was anything going on? The answer was no, no, no. And the not really funny thing is, but the funny thing is, her husband was walking out of the room. He said, wait, honey, come back in. You were abducted and held at knife point in that store a month before this started. And he looked at me and said, Doc, could that have anything to do with it? So that is an example of pain for psychological reasons, if you want to call it that, trauma-induced hyperalgesia. And she got better with treatment of trauma. For the most part, she slept better and went back to work. This is a typical patient, chronic pain patient from a primary care clinic. This is a real set of answers from a real patient, de-identified, from a local community health clinic, who came in to the primary care provider with severe pain. This is a different patient now. Severe pain, 5 out of 5, really intense, and it's bad. And lo and behold, on some of their screening, this clinic did an anxiety screen. He maxed out the anxiety, 21 out of 21 on the GAD-7. PHQ-9 was 16. That's moderately severe depression, not suicidal. But lo and behold, we asked them to do this. This is the ACE questionnaire. Yes to sexual trauma. Yes to being slapped, abused. Yes. The only one this person missed, says 9. 1, 2, 3, 4, 5, 6, 7, 8, 9. Was, I'm missing which one it was. But they just missed 1 out of 10. This is an ACE score of 9 out of 10. This is a severe sustained childhood developmental trauma patient that explains the depression, the anxiety, but also the patient was labeled a chronic pain patient with, I believe, fibromyalgia, rheumatoid arthritis, and a couple other diagnoses. Maybe chronic Lyme disease for that one. This one needs trauma treatment. So to summarize then, there's nociceptive pain, a noxious stimulus is required. This is the kind of nociceptive pain is what we all understand to be acute pain. We've all had this experience, toothaches. Neuropathic pain, many of us haven't had this, from either physical nerve injury or I'm going to say from experiential nerve injury. So that's the first three types, and then emotional pain. Now a person can have all four, can have two of the four, can have one or it can have three of them. And those are the difficult ones that have actual physical injuries that damage tissue that were probably traumatic, and maybe the treatment was traumatic, and they start to have all of them. But the implications for treatment are where we need to go with this. When you have pain from tissue damage, the nociceptive pain or the neuropathic pain from nerve injury, diagnose and treat the physical condition causing the pain. Well, this is what we do in the medical system. We palliate the pain, we treat co-occurring psychological distress related to pain and loss of function, help them engage if we need family therapy. But if we diagnose instead pain from traumatic experiences, so-called trauma-induced hyperalgesia, I'm making that up in the last year or two because we don't have terminology for it. The first step is to diagnose and treat the trauma and any mental health sequelae of the trauma. And what you don't see is further attempts to work up tissue damage because there isn't in that case I gave you of the woman who had pure pain from a traumatic experience, trauma-induced hyperalgesia. So there's a lot of other implications. So I'll sort of speed over for time's sake. Do opioids work for chronic pain? Well, the conventional answer is no. And this is from Eriksson in Denmark. Did a study of the population, the Public Health Service in Denmark, and found that opioid usage was significantly associated with reporting of severe pain, poor self-rated health, not being engaged, higher use of the healthcare system, and a negative influence on quality of life. That opioid actually made people worse. And this is one of the things we really hung our hat on back about 10 years ago to say maybe chronic opioid therapy isn't such a good thing. And to some degree that's true. However, that study and another one that I'm referencing down here don't exclude people using opioid to treat anxiety, to address their trauma, that sort of thing, or as part of an addiction disorder. This study down here by Krebs actually said in their methods section that patients with severe depression and post-traumatic stress disorder were not excluded because these patients often receive opioids in practice. Well, that's the point. What we have in our research on opioid effectiveness is a heterogeneous population. We have people with emotional pain and or trauma-induced hyperalgesia, pain that's related to central nervous system sensitization from trauma, psychological trauma, mixed in with people with bad knees and injuries and that sort of thing. We really don't know if musculoskeletal and nerve injury pain, the first two types of pain, is responsive to opioid or not because we've studied all these groups together in all the studies. We have not screened, just as we don't in our offices, we didn't screen in the research, have not consistently screened out people with significant trauma and other psychological histories. So it's a mixed bag. So the opioid research really doesn't tell us much other than if you take all comers. Anybody who says I hurt and you give them opioids, chances are it won't work in the long run. We don't know about someone with nociceptive or neuropathic pain from injury. So another thing, how we conceptualize pain and talk to patients typically is a search for the tissue damage in the body, right? That's just nociceptive pain. That's the beginning and the end. So, but when we're talking to patients, it behooves us, when we're talking to chronic pain patients, to also open up an examination of the nervous system, where neuropathic pain from physical nerve injury or experiences kind of lives, changes in the way the nervous system processes pain stimuli. Or the mind, emotional pain I put there, just a little bit arbitrary. Not like this. Mind-body really doesn't do it because if it's not in the body, If it's not nociceptive, it must be in the mind, and most patients will reject that. They don't like that idea. It's a sign of weakness that you have, you just can't tolerate the pain. The hyphen in between the mind and the body is the nervous system. So an implication of these 4 different types of pain, keeping them all in the front of your mind as you're addressing someone with chronic pain and trying to help them, the implication is that pain might be coming from the nervous system, not the mind. And the mind-body concept we need to just throw out and name the hyphen. The hyphen is the nervous system. Pain can come from any of the 3 areas or all 3 at once. So that really helps us talk to patients about where their pain's coming from. I've found it very helpful telling people I think your nervous system has changed as a response to the developmental trauma, and that's led to a lot of fatigue, that's led to your chronic pain, your fibromyalgia and other things, and we can treat the nervous system. It's not in your head. That's where I'm going with that. So let's talk briefly about the opioid crisis. When we ask ourselves who these people are that were accidentally overdosing on prescription opioid, who are these people that then moved on to use heroin and fentanyl and overdose? Well, they're certainly not addicts. Back in the day, the thing that really set off our alarm bells in 2005, 2010 was a dramatic increase in overdose deaths from a first use at a party from kids, that sort of a thing. Now, they might not have even had a beer or smoked a cigarette, but they tried an OxyContin 80 and they didn't wake up. So that's one population that's certainly not an addict. People prescribed opioids suffering a chronic painful illness, nociceptive or neuropathic due to tissue injury, that they respond to opioid with, but being dangerous drugs, they accidentally overdosed, certainly. People with addiction disorder, opioid use disorder and more, accidentally overdose, certainly. But now, number 4, now we can see this. So this lecture is intended to shine a spotlight when it comes to the opioid crisis on this group right here. People with trauma-induced hyperalgesia using opioids to treat the trauma, the PTSD, the depression, anxiety. And remember, I told you that opioids are good for that, and we don't have time to go into it, but there's pretty rich animal and human experimental data showing that opioids are pretty good for treating anxiety and to some degree depression. We're starting to see publications regarding use of low-dose buprenorphine for treating depression, for example. So my thesis again is that many of the people who have overdosed when it was on prescription opioid, and more often now because we've limited our access to prescription opioid, might have tried street drugs, are people with this experiential neuropathic pain, trauma-induced hyperalgesia. How many? Well, a lot. Remember all the diagnoses? Think, how many people do you think have this in their chart? Something like that. There's a lot of folks that have acute Lyme disease or small fiber neuropathy, things like that, and rheumatoid arthritis, but many people have this stuff in their chart. If you talk to their rheumatologist or their medical doctor, they'll say, I don't really think that's it, but I just don't know what it is. Millions. According to CDC, 20 million or 40 million. So implications for helping people get off pain meds, get off that pill island. That's pill island. That person is stuck. So we've got people still on a lot of pain meds. We need to recognize, based on what we've just talked about, that people could have trauma-driven pain and no opioid use disorder. That is possible. They might be using opioid as a psychotropic. Now, people might have nociceptive or neuropathic pain and no opioid use disorder, but they have side effects. They're on too much medication. Maybe they want to get off. Maybe they think they've developed opioid-induced hyperalgesia. Then we've got people with opioid use disorder, and they may or may not have pain. And then we've got people simply treating anxiety with the opioid, no real pain. So there's a mixed bag of people on pill island, and if you look at this, you're going to see, wow, the approach is going to be really pretty different for someone with opioid use disorder, nociceptive pain, and someone who has trauma-driven pain like that patient I showed you. By the way, she was on 200 milligrams of oxycodone a day when I first saw her, that one that I showed you the pain diagram on. I said opioid is used as a psychotropic, and I'm going to back it up with at least circumstantial evidence. Lots and lots of anecdotal evidence. My experience and my colleagues has been that the majority of chronic pain patients are using their opioid as a psychotropic. That this is research showing that an American with depression or anxiety is much more likely to be prescribed an opioid painkiller than an American without those diagnoses, and that the majority of people getting opioid painkillers, that 51% of those people, 51% of the opioid in this country, goes to the 16% with significant mental health problems. Trauma is treatable for solving the opioid crisis, but remember, we don't screen, we don't diagnose, even sometimes in the mental health level, apparently, and so we're not going to pick it up, but also the treatments aren't particularly expensive or difficult, but the treatments aren't readily available. So if you treat the trauma, the idea is all those bad things will likely go away. Now, for time's sake, I've included trauma treatments, which I'd love to go into a little bit more details. We don't just say treat the trauma, but the heavy-duty ones are the neurocognitive therapies, EMDR, prolonged exposure therapy, cognitive processing therapy, and somatic experiencing, or its new organic intelligence derivative. And there are others, many others, medications, diet and exercise, alternative approaches, sleep. All those are important. Family therapy can be important, et cetera, and group therapy. It can be easily screened for, trauma can, at low cost. So if we did that, we'd avert the crisis. And what I'm talking about on my slide is I'm talking about behavioral medical integration. And as many of you probably know, since almost 6 years, we've had, thanks to NASCSA on their website, of what integration of behavioral and medical is. They've actually laid out 6 levels. The top level is level 6, where there's full collaboration and a transformed, merged, integrated practice. If you all, anyone listening to this is wondering, well, so what should we do? If we don't screen and we don't treat trauma, well, NASCSA has sort of laid out what transformation needs to occur in our medical practices, in our healthcare system, to integrate behavioral and medical, properly screen for trauma, properly treat it, and reduce a lot of the issues we're seeing, including probably finally get a handle on the opioid crisis. But there are a number of reasons that we don't do that, and they have to do with the way the system is organized. There actually is better reimbursement for getting behavioral health people involved with primary care, and reimbursement to primary care to work with them that is aimed currently only at the community health centers, the FQHCs in our country. That needs to be taken nationwide throughout all levels of care. With that, I think I'll stop. And Kathy, I think I saw you on there. I'm going to stop sharing, and we are at just a little after 12. I don't know if we have time to do questions or not.
Well, thank you very much. This is Shannon again.
Hi, Shannon.
Hi. I think just based on time, we're going to go ahead and wrap up, and your slides have a wealth of information on them as well. And we're going to get those posted on the NASCSA website. And Dr. Davis, is it all right if we have your contact information, which is, I believe, on one of your last slides? So if anybody has any specific information, they can reach out to you with any questions. Is that all right?
Absolutely.
Okay. Well, thank you very much. And we'll get the webinar posted as soon as possible. And again, everybody, thank you for your patience with our technical glitches at the beginning, and hopefully we won't run into that again. Dr. Davis, thank you so much for being with us.
Yes, thanks, everybody. My pleasure.
Have a great day, everybody. Thank you. All right. Dr. Davis, thanks again. Sorry about the hiccups in the beginning there.
Yeah, that was weird. I could hear